Nitinda ma'am, I think we can start now.
Okay.
People will join.
Yeah.
During.
Yes. Good evening, everyone. I am Dr. Melinda, and I welcome you all to the ninth discussion forum of this month on the topic of prediabetes and nutrition, evidence-based dialogue. So, coming to the main part of it, like before we start into the prediabetes and nutrition, I would like to talk about PEN, what PEN does basically. So, can I get the next slide, please? Yes. So basically, PEN integrates evidence-based nutrition in healthcare, which basically empowers the healthcare professionals and facilitates the education in the medical space. It also acts as advisory to policy and industry, which helps to create better food systems and achieve nutrition equity. Then it also improves the knowledge on nose house, where it helps to increase like the knowledge about healthy eating environments and food systems. It also participates in partnerships and collaborations, which basically increases the knowledge, integration, and sustainability of the programs. Lastly, it is mostly acting on public awareness creation by educating community. Then, what is the aim of our PEN? The next slide, please. Yes. So the aim of the PEN is to revolutionize the healthcare to a whole person care model with evidence-based nutrition at the core metrics, and the mission is uh, to address the multitude of these issues related to dietary choices of people in India by facilitating better healthcare systems, healthier and safer food environment, and public awareness. Coming to the leadership board, the advisor of PAN International is Ellen Thornburg. Then the co-founder and current chairman of board of PAN International is Nicholas Oppenrader, and medical director of PAN India is Dr. Rachna Shaheen ma'am. Coming to the next slide, where you can see the Medical Advisory Council, which consists of Dr. G. Rajendran, Dr. Arun Kalyan Sundaram, Dr. Sharang Bhatikar, Dr. Rupa Shah, Dr. Narsim Allah Srinivasla, Dr. B. Santosh Kumar. Now, the Pan India team consists of medical doctors, nutritionists who contribute as program managers, ambassadors, volunteers, and PAN is actually open to all the volunteers who want, like the doctors, faculty, or medicals who wants to be a part of this team can be like either as volunteers or ambassadors. Coming to the introduction of the panels today, first we have Dr. Varsha Shah. She's a pediatrician, practicing pediatrician with special interest in adolescent medicine and lifestyle medicine. She's a consultant at SBKS Medical College Medical Consultant at Sharon, an organization which helps people in disease reversal. She's a consultant at Prakruti Heal for disease reversal and holistic healing. She's currently pursuing PGDLM. Then Dr. Anjali Nakra. She's a family physician, has international board. Previous slides, please. Yes. So she's a family physician and has international board certification in lifestyle medicine. She's certified for obesity management at the World Obesity Federation. She's trained in mind-body medicine and motivational interviewing and CBT insomnia. She's a founder of Path to Health Clinic. She's a member of American College of Lifestyle Medicine and a co-author of the book How Healers Heal. Next, we have Dr. Bijli Nanda, ma'am. She's a board certified lifestyle medicine practitioner. She also served as a professor of physiology at Sharda University. She is also a certified. She's also certified in evidence-based diabetes management, integrated geriatric care, cancer exercise specialist, and palliative care. She is currently practicing lifestyle medicine and palliative medicine at My Health Clinic in Noida. Then we have the Miss Ila Pathak. She's a certified nutritionist with master's degree in dietetics, certified in nutrition and childcare. She is also in plant-based nutrition. She's a strong advocate for plant-based lifestyle and incorporates it into her own life. Additionally, she helps people to correct their chronic disorders by helping them understand the science behind this lifestyle. She is currently practicing at KB Health. Sorry. Now, before we go to the questions for the panelists, I would like Dr. Vindya ma'am to introduce this topic to the public. Vindya ma'am, over to you.
Thank you, Dr. Melinda. Good evening, everybody. So, in the light of increase in the incidence and prevalence of type 2 diabetes worldwide, and India being the highest prevalence country, numerous studies have focused on early identification of individuals at risk of developing this disease, so as to be able to implement interventional strategies to delay the onset. This has led to the recognition of the term prediabetes as a dysglycemic state straddling normal glucose tolerance and the frank diagnosis of type 2 diabetes. Prediabetes, in fact, is a term used to indicate a condition in which blood glucose levels are suggestive of abnormal glucose metabolism but are not yet able to meet the diagnostic criteria of full-blown diabetes. The rate of progression from prediabetes to type 2 diabetes is about 25% in 3 to 5 years. It is estimated that 70% of the individuals with prediabetes will develop type 2 diabetes in their lifetime. If untreated, 37% of people with prediabetes could develop type 2 diabetes in 4 years. However, where appropriate lifestyle changes are made, long-term studies have shown that the risk of progression can be reduced by delaying the onset of type 2 diabetes to 10 years, avoiding long-term complications related to type 2 diabetes. In this sense, lifestyle intervention appears to be very promising. Diet is one of the lifestyle intervention. It is an important modifiable lifestyle determinant in the development of type 2 diabetes. Among these dietary determinants, plant-based foods have been associated with a lower risk of type 2 diabetes. The role of diet in health may be better described by overall dietary patterns. So today, let's dive into the topic of evidence-based nutrition through whole food plant-based diet in the interventional role for prediabetes. So let's begin with our first discussion. Our first question goes to Dr. Varsha ma'am. So what strategies, parameters, and novel biomarkers can primary healthcare providers employ to enhance the screening and early diagnosis of prediabetes? Also, are there any diagnostic methods that minimize the testing burden and improve the prediction of prediabetes and its consequences? Over to you, ma'am.
Good evening, everybody. Thank you for this opportunity. Now, what the main question is, what are the strategies, parameters, and novel biomarkers that healthcare providers can employ in screening for early diagnosis of prediabetes? Now, in my practice, what we do is first, whenever we have a patient who's primary diabetes, we screen the family members for prediabetes. So especially because I'm a pediatrician, we screen the children. So if any patient is there who has a family history of diabetes, you can screen for prediabetes. Secondly, if they have history of gestational diabetes, you screen for prediabetes. If there's history of metabolic syndrome or PCOS, polycystic ovarian disease, then also you screen for prediabetes. And these are the factors. Then when you see the patient, for that matter, any history of obesity, where the BMI exceeds 23, where the patient is overweight or obese. Second is if the patient is having an abdominal circumference which is more than, say, 100 or 88, depending on men or women. And you have an abdominal circumference to height ratio, which is more than 0.5. Okay. So abdominal circumference, why is it so important? Because it is a marker of visceral fat. Visceral fat is an indirect marker of liver fat and pancreatic fat deposition, which predisposes to prediabetes and diabetes. Because as we come to know the physiology in the next step, we will know that visceral fat is one of the strongest indicators of developing prediabetes in the near future. So abdominal circumference, for that matter, is extremely very important. Then we have other markers like waist to hip ratio, if it is more than 0.9 in men, and if it is more than 0.8 in women. Then we have, of course, then we have other measurements which, if possible, and if you're doing in your practice, that is skin fold thickness. A tricep skin fold thickness more than 20 mm in men, or more than 25 mm, 25 mm in women and 20 mm in men, if you're measuring the skin fold thickness. So in general, this is how you would screen before going invasive, actually doing the blood sugar or the other lipid profile and all. So this is, am I audible clearly?
Yeah, we can hear you.
Yes, ma'am. Yes.
Yeah, okay, fine. So what I said was, first we ask the history, where we take the history for family history of diabetes, gestational diabetes, metabolic syndrome, and this thing, polycystic ovarian disease. Okay, and if once we see the patient, there's this obese patient, and even if he is a non-obese patient, his weight is normal, his BMI is normal, but he has abdominal circumference, abdominal obesity, which is a marker of visceral fat, that is where you will screen the patient for pre-diabetes. Okay, so the various methods are the BMI, the abdominal circumference to hip ratio, the abdominal circumference to height ratio, the skin fold thickness. And nowadays, because we have body composition analysis machines where your body fat percentage is more than 25% in men and 35% in women, or you have a visceral fat percentage which is more than the upper limit of normal. All those patients are patients where you would screen for pre-diabetes. Okay. Then we come to the blood testing. So according to the ADA, it is fasting blood sugar between 100 to 125, or a postprandial blood sugar between, say, 140 to 199 is a marker of pre-diabetes, along with an HbA1c exceeding anywhere between 5.7 to 6.4 is a marker of, it indicates pre-diabetes. So these are the basic blood tests which will confirm that the patient has pre-diabetes. Usually when we get these blood tests done, we also do a complete lipid profile, liver function tests, inflammatory markers like CRP and uric acid along with it, to know whether there is associated dyslipidemia, associated fatty liver disease, which commonly accompanies in obese patients. And if there are markers of, just surrogate markers of inflammation, like CRP and uric acid, or these are the markers we generally get tested in each and every patient when we are testing for screening for pre-diabetes. Now, there are other research markers like fructosamine and all, but they are still not there into daily practice, and I have no experience of using those markers. So these are the diagnostic methods that we generally employ in daily practice to screen for pre-diabetes. Yes, ma'am. Fasting insulin also we do. We do a fasting insulin with sugar and a HOMA-IR. That also helps because fasting insulin does definitely help in because the mechanism is basically insulin resistance. You will have hyperinsulinemia, and that is also gives you an idea that the patient has pre-diabetes. But most important, you will get most of the times your sugars, blood sugars, fasting and postprandial values, along with an HbA1c, gives you the criteria for pre-diabetes. I usually do fasting blood sugar and HOMA-IR when I am in doubt whether it is, borderline, that type 1.5 diabetes, or when it is an overlap between type 1 and type 2. So that is where I usually get fasting insulin and HOMA-IR done. I am done with the question. Anyone has any ideas? Because my experience is mostly with adolescents with pre-diabetes and diabetes, and of course, some few patients of diabetes that I see in my lifestyle practice. So to be very frank, I've come across a lot of patients with pre-diabetes and adolescents. In fact, frank diabetes, because we are seeing childhood obesity explode. So the youngest patient of pre-diabetes that I have seen is a 12-year-old boy. And between the ages of say 15 to 21, we see a lot of patients, both obese and non-obese. Now, when we go through their lifestyle evaluation and all, one most important thing that we come across is along with a wrong diet, there is a lot of physical inactivity that we see. So I have seen a lot of children, say between the ages of 15 to 25, young adults with pre-diabetes and diabetes. And almost universally, most of them, 95% of them are type 2 diabetes, means pre-diabetes and type 2 diabetes. I would love to hear if there are any other additional criteria that we use in screening or diagnosing pre-diabetes.
Ma'am, did you say about acanthosis?
Yeah,
Marks?
yeah, acanthosis nigricans and skin tags, you know, those, these
On
are
the
two
neck.
conditions. Yeah, these are
Yeah,
two
okay.
clinical conditions, which again, all such patients you have to screen for pre-diabetes. So acanthosis nigricans I've seen as early as say 7 or 8 years of age. And even if the reports are normal, we follow them up every 6 months and get them tested every 6 months. So putting those lifestyle interventions early is very, very beneficial. The youngest child that I have seen with acanthosis nigricans is again 6 years old. But his metabolic profile was absolutely normal. But of course, children above 12 years and all, they have a either dyslipidemia or elevated sugars. There's an usual association of pre-diabetes. And if it is not there, you have to monitor them in, you know, like frequently, and they may develop it in the near future.
Thank you, ma'am. So let's move on to
one more question, ma'am. Excuse me, ma'am.
Okay. Okay.
Yeah.
Ma'am, I'm a general dentist. I'm a periodontist. So usually when many of the patients comes to my dental clinic, I usually check their routine random blood sugar level. And usually I find quite evident it's around 140 to 199. And later I took HbA1c values, ma'am. So what should I take it into consideration, whether I have to go with random blood sugar or HbA1c for diagnosis of diabetes? Usually I'm getting around 6 above, ma'am. Most of the time I find these cases, ma'am.
So if it is above 6, it is definitely pre-diabetes. See, these the WHO criteria is 6 to 6.4 pre-diabetes, and ADA says 5.7 to 6.4. So above 6, the chances of proceeding to diabetes is very high. So you should start with lifestyle interventions right there and then if it is above 6. It is pre-diabetes, and the chances of progressing to diabetes in the next 3 or 5 years is almost 70%, I would say, without any changes or interventions.
So what I should recommend them? What is the lifestyle? What is the first line of modality when I come across? Why? Because mostly throughout my PG, I have come across many of the patients when they come for routine dental extractions. I've seen many patients with diagnosis of pre-diabetes cases, ma'am. So I'm in dilemma. Why? Because
so the next
sixth complication is the periodontal abscess. So I find so much interesting. So I, being a dentist, how able to diagnose many of the diabetic patients. So it makes me wonder how to deal with those patients and what should I recommend to them, ma'am? What would you prefer? What does it?
So you do screening before treatment for every dental patient that comes to you?
Yeah, ma'am. No, depending upon their age, after knowing their case history, and depending upon their oral condition, by seeing their case history, I get a doubt Why? Because usually patients are around 30 plus and coming with multiple periodontal abscess and history of hypertension. So I think on others out of the box, and I'll go with routine RBS, ma'am. Then if it is around 140 to 200, then I'll go with HbA1c. Then I will think, okay, whether he's diabetes or non-diabetes. Then I will recommend him to the general diabetologist. So what I should recommend before referring them, I just directly go with the routine medication of metformin, or I should recommend them the diet so that
Yeah,
they
so
can
now,
avoid the medication.
yeah, so this patient needs a complete lifestyle evaluation, and plus how much he or she is committed to work towards the changes in diet, the changes in physical activity, sleep, stress reduction, getting rid of addictions. So all these 6 pillars have to be assessed. And the most important of them, I would say, is diet and physical activity, which we will come to in the next question that is there.
Yeah, okay.
Okay, ma'am. Thank
We'll
you,
move
ma'am.
on to the question number 2 now. Ma'am, the question is for you. Now that based on the blood glucose levels and other parameters, you have decided that a patient is fit for the intervention, how will you approach this patient? In other words, how intensively do you treat such cases?
Yeah. So usually when the patient comes to me, we take time and sit with the patient and tell him, see, as of now, your report is not diabetes, but it is pre-diabetes, which is very fortunate because you have the chance of not being on medications if you change the trajectory, means if you change your lifestyle. So changing your lifestyle may prevent the progression of this pre-diabetes to diabetes, but you have to be committed enough. So we assess that this thing from them. And when usually they have seen their parents suffer with injectables, insulin, in some cases CKD, they are, there is some fear factor which makes them work towards changing their lifestyle. And this is for youngsters. And second category is again the people who work in the IT industry and all. They develop diabetes at a relatively earlier age, say 28, 29, 30, 35, as compared to the parents who have developed it after 40 years of age. So again, they are very keen on saying, I don't want this to progress. So that phase of where, where they are mentally ready to make the changes, then we give them the option of changing the diet. The first most important is moving towards a whole food plant-based diet. So we explain to them that, see, diabetes is majorly because of fat deposition. The basic mechanism is an interplay between the liver, the pancreas, and the muscle. So the excess calories or the excess food that is there is converted to fat and is stored in the liver as fat and is stored in the muscles as fat. So that fat is preventing the entry of blood glucose into the cells. That is why it is remaining in the blood. And the end result is hyperglycemia or increased sugar. So we all know that where the intramyocellular fat prevents the absorption, binding of the insulin to its receptor and opening of the glucose channels. So that we explain in regular terms and tell them that 80% of your sugar is utilized by the muscle. So if you have no physical activity, then that uptake by the muscle is again going to be less. And for this Asian population, already our BMI is like, say, above 23 is overweight and above 25 is obese, as compared to above 30 obesity across the world, for the Caucasian population. Already we are more prone to develop diabetes and chronic diseases, being a Southeast Asian or Asian population. Plus, having the wrong diet and no physical activity increases this propensity, So first comes as diet. So whole food plant-based diet. So what I explain to them is consuming the power plate. What is the power plate? Is you have 25% or 1/4 should be vegetables, 1/4 should be fruits, 1/4 should be legumes and pulses, and 1/4 should be cereals, either rice, wheat, or millets. So this is the basic power plate that we explain to them, that whenever you have major meals like lunch and dinner, this should be the proportion. So 1/4 fruits, 1/4 vegetables. So 1/4 should be at least raw, whether it's fruits or salads. 1/4 should be cooked vegetables. 1/4 should be legumes, dals, and pulses. And 1/4 should be cereals, whether rice, wheat, or millets. Now, in our routine Indian population, what happens is the consumption of carbohydrates is very high. If I asked any mother, no, what does your child eat? Subah 4 roti khata hai, 1 katori rice, and evening 3 rotis. No one will mention how much dal or vegetables the child is eating, or the salad or fruit. Okay. So when we design a diet or change in the food intake, we advise, one thing is, this is the power plate. Second is reduce consumption of all fats. So fats are present in what food? The best way to explain is when you boil anything and fat comes on top, all those foods are fat. So all animal products, whether it's fish, egg, meat, chicken, and milk. When you boil milk, the fat is deposited on top. So that is how I explain to my patients that all these products have to be out from your daily routine. So either, if they cannot, at least reduce it, especially for dairy. Okay, because this parents are so influenced that where will I get my calcium from and where will I get my protein from? So that is what you explain to them. So first thing in the morning, get up, go for a physical activity. Pre-physical activity workout, you can have bananas, apples, or fruits. Come back, again, have either a green smoothie or fruits along with your breakfast, which should be cooked breakfast made at home, not something like chocos and cornflakes and low-calorie cornflakes. It should be something like, millet upma or moong dal chila, or a sprout bhel, or something like red rice poha with lots of vegetables, or vegetable idli. So these are the breakfast options that we give the patient, where we say that have food with a lot of fiber and vegetables. Try to add as many vegetables as you can to whatever you can make. So that is as far as breakfast is concerned. Snacks should be fruits or something like roasted peanuts, roasted chana. Then lunch is power plate, 1/4, 1/4, 1/4. Again, dinner can be the same power plate, or it can be soups, meal replacer, salads, or whatever, like if you're having pav bhaji, instead of the pav, you have roti with bhaji or paratha with bhaji, because bread is again ultra processed food. Then, whatever South Indian food, or chole with paratha, but without ghee. Okay. Some oil is allowed in that, but excess oil in the form of fried food, maida, white rice, added sugar or sugar, sweets, all this is something we say that avoid. And once the patients follow this lifestyle of having whole food plant-based, they lose weight. And once they lose weight, their sugar control also improves. And they get that confidence that, okay, fine, I will be able to do it. Second most important thing is physical activity, because 80% of the sugar is utilized by the muscles. So if you're not having physical activity, your postprandial and otherwise also sugar control will be very poor. So minimum is like 150 minutes per week, up to 300 minutes per week, which should be moderate intensity, where you cannot talk one sentence continuously. You go out of breath, your heart rate increases, your sweat increases. That is moderate intensity physical activity. It is not a leisure walk. So if you have a patient who says, I walk 30 minutes every day, I would say walking is an exercise after the age of 60 or 70. Before that, you have to have all the 5 components, That is cardio, endurance, strength training, like flexibility and posture. All these 5 components of exercise should be included in your daily physical activity. So if they're doing walking, we suggest that jog a little, walk a little, or enjoy sports that you play, whether it's tennis, whether it's swimming, whether it's badminton, and at least minimum 8,000 to 10,000 steps per day. So that sedentary lifestyle is, you make them more active. Sleep. Third is intermittent fasting. Intermittent fasting, if possible, you start with say 10 or 12 hours of intermittent fasting, because that gives better control of sugars. Earlier dinner, and so if preferably 2 to 3 hours before sleep, dinner, and then morning, like I don't advocate 14, 16 hours of intermittent fasting to all patients who cannot do it. So that usually is for difficult to control diabetes and all. And pre-diabetes, 10 to 12 hours is also good enough. And timely sleep, gadgets off at least 40 minutes before sleeping. So good quality sleep brings down inflammation. So that is again very, very important. And of course, at least minimum of 6 to 7 hours of sleep is mandatory. Last is stress reduction and, good interpersonal relationships, whether it is with family, friends, colleagues, at workplace. So this is what we in general is the approach we give for treatment of pre-diabetes. And then home-based monitoring. So home-based monitoring for blood sugars, and then we follow them up, usually after 2 weeks, as to how much they are approaching, how much they are able to do. So we ask them to maintain an activity log for, say, food intake. They have to have at least 3 servings of minimum fruits, 1 serving of vegetables. So they tick in their food journal. Second, we maintain an activity log. So they send a screenshot of how many steps they have walked, 6,000, 7,000. So within 1 week, they have to reach, say, 10,000. And 1 hour of physical activity, whatever, 30 minutes to 40 minutes of physical activity other than this 6 to 8,000 steps. That is what we usually tell them. So at least if they can do this 5 days a week, it's good enough. So we maintain a food
Varsha ma'am,
journal.
it's
Yeah.
time.
Yeah,
The time, sir.
Okay.
Sorry for interrupting you, ma'am. But we have similar question in the discussion meeting. So I think we can discuss this point there.
Yeah,
And thank you. Thanks a lot for your insights.
thank you.
Okay, moving on to the next question. This is for Dr. Bijli ma'am. Ma'am, how do you see the pharmacological therapies in relation to evidence-based nutrition interventions in pre-diabetes care, especially for the patients who are at risk of or have cardiorenal issues? Bijli ma'am?
Yeah.
Okay.
Yeah, can you hear me?
Yes, ma'am.
That's a very interesting question, Vindhya, because a lot of times we are wondering whether we should give medication to a patient or not if the patient has pre-diabetes.
Yes.
So I think in practice, what we like to do is first figure out how much is the risk of that particular patient for other comorbidities. So somebody who comes to us with pre-diabetes, first you try and assess whether he or she has any other, not just cardiorenal, but even other, other issues also should be addressed, whether it's only pre-diabetes or something else. So that's the first thing. Pre-diabetes itself is putting you at risk for cardiorenal disease. So the low risk is already there the moment you're diagnosed with pre-diabetes. But the risk becomes higher, let's say, if a person is obese, but somebody with a BMI of 27 versus somebody with a BMI of 30 or more, obviously the risk is different. Now, if there is a patient who already has a cardiorenal disease or any parameters which are off there, that person may or may not have already started medication. So if they're already on medication, obviously you don't want to interfere with the medication. But yes, you would like to start the lifestyle interventions as soon as possible, because the earlier you start the interventions, the more intensive the intervention is, the better the results. However, with cardiorenal issues, since the question is mainly about cardiorenal, we'll just stick to that. With cardiorenal issues, you have to individualize. You cannot just have a general, one size fits all. As with lifestyle medicine, in any case, even nutrition aspect or exercise, everything has to be individualized at the end. So if the current recommendations also for pre-diabetes are to start with lifestyle modifications, and nutrition is one of the most important aspects of that, of the 6 pillars of lifestyle. So you do start with nutrition advice and address that issue first. Now, the recommendations for starting drugs are given by many bodies, but still lifestyle interventions are the first recommendation. Now, whether you continue that for 3 months or 6 months is debatable. For example, RSSDI recommends that if after 6 months you don't see any benefits, then you start with drugs. Now, drugs being the first drug to try would be metformin. If there are no other major issues, if you're simply dealing with prediabetes and obesity, then metformin was a good one to start with if you don't see any results in 3 to 6 months. Results with lifestyle interventions. However, if there are cardiac issues or renal issues, then you would like to start with SGLT2 inhibitors or GLP-1 analogs. Now, there, of course, you need to look at the history of the patient, whether the SGLT2 inhibitor or GLP-1 would suit them. You also have to look at the cost of these drugs, because they are much more expensive, and while lifestyle interventions themselves also can be expensive to patients initially, in the long run, they're not going to be expensive. So it is worth trying to get them to, do the interventions in an intensive manner rather than to quickly just start drugs, right? And I think there would be a discussion on how to get the patients to, how to get them to be on those lifestyle interventions in a proper manner so that the benefits are seen. But yes, I would wait 3 months at least, reassess. In 3 months, you can at least figure out whether your patient is really going to make any of those changes or not. If you can figure out whether it's possible to keep them on that path, or if somebody is progressively worsening with the blood sugar levels or weight issues, then you might want to just start a medication.
Thank you so much, ma'am. Anyone else would like to, whoever has any questions can be the question will be taken at the end. So moving on to the next question, that is for Dr. Anjali Nakra, ma'am. Yes. How can we promote long-term adherence to evidence-based nutrition and lifestyle interventions for individuals at risk of prediabetes? And what strategies have proven most effective for patients' compliance, especially when they haven't started manifesting the disease yet? Dr. Anjali, ma'am, over to you.
Yeah. Thank you so much for organizing this discussion. I think it's really an important, very important topic. So I think a lot has been said about what to do. I will just focus on how we can get our patients to do that, to do all the followed lifestyle modifications. So having said that, the DPP program has given us so much of positive inputs that lifestyle modification wins over metformin as an intervention in pre-diabetes and improves the and actually helps to delay the or stop the progression to diabetes. But getting our patients to make behavior change and doing the lifestyle modifications is a process which we need to look at it from a perspective. This, if a patient with pre-diabetes has to be educated what is the risk ratio of developing diabetes. So 7 to 10% of people with pre-diabetes will progress to diabetes in the next 1 year. And as Dr. Varsha, 70% of patients will end up with diabetes. But it's a process to get them to follow lifestyle modifications. Just telling them to change and that it will have a beneficial impact does not work, especially in the longer term. So strategies to help patients change have to be used on various in fact, on all behavior changes, all different behavior changes that we want them to make. And various techniques can be used. We have to really spend time with the patient to give them a realistic picture. So the first thing is to find the contributing factors which have led to pre-diabetes, the triggers of which lead them to eat in an unhealthy way or not exercise or have some addictions or for smoking, alcohol, so for not sleeping enough. All these triggers have to be identified. We have to identify what is their attitude towards these various lifestyle domains. What is their education level and awareness, and how motivated they are to change, and how committed they are going to be. So while we have a lot of behavior change interventions like motivational interviewing, cognitive behavior therapy, to help them to go a step ahead, it's a process. And it takes time. It takes a lot of interaction with the patient. So we can go on to learn to use techniques from various the behavior change theories. So trans-theoretical model by Prochaska and Clemente, where we match the intervention to the stage of change, is a very effective strategy. So for example, somebody who's not even ready to think about a change, and we start telling them, no, you must go for a walk every day, you must do this, you must do that. I mean, it's not going to happen. So we need to be sensitive about where the patient is to help them to go one level up in the stage of readiness, and then work towards getting them to make the change. What works is tracking their lifestyles. We can help them to set goals, maybe some rewards, and planning how to change their habits rather than kind of saying, okay, you need to start eating vegetables, but how are they going to practically implement this? That is important, and I think Dr. Varsha has given very good example of gradually starting to get them to eat vegetables, and fruits, and looking at it in a for the plate method. I think that's a very helpful tool. Digital tools these days are very easily available, and they can be very helpful. Online support, education. These are also very helpful, and I think technology can be really used to, we can take help from technology to interact with the patients and keep on giving them kind of reminders as to how they, reminder that they can keep changing. So group programs like the DPP program in the Western countries they are mostly group programs, and these are so the group programs are helpful. Family support has to be assessed, and the family also needs to be put into to be brought into the the whole picture, and the support from family is very important. Sometimes peer groups, they are helpful. So we need to identify what where which is the domain where we can work more. It's like working on the strengths, and while we focus on the weaknesses also, but to get the strengths of the person, and and to identify the strengths of the person and work first on those. It's like working on the low hanging fruit. And so another way to look at it is to look at the capability of the patient. What are their physical and psychological skills? To what is their existing level of knowledge? To add to that, what opportunities do we have? The external behaviors which can also help us, the environment, the social cues, what are the cultural norms, and what and of course finally motivation levels. What are the in what way can we help them by our techniques, by motivational interviewing and cognitive behavior therapy, and to find out what are the trigger behaviors and work on those, and making plans, setting goals, having action plans. All these things help a person to make those long-term changes and stick to them. Because short-term, yes, it's easy to okay, I'm going to eat vegetables, I'm going to go for a walk every day. The critical point where they stop, and in a week's time or 2 weeks' time, that is what we need to focus on for the long term impact of lifestyle modifications.
Thank you so much, ma'am, for your insight. From this, if I want to take away something, I would say that baby steps is what we have to focus on rather than just jumping onto the patient directly for the entire thing. If I'm not wrong, I'm right.
Yes, I think I here I would like to say it is helpful to even to make. I mean, let me sum up in a way that we should focus on the targeted needs of the patient. And we need to, while we have our programs in place, we need to design personalized programs, as mentioned earlier, and the focus and the focus should be majorly on goal setting, action planning, monitoring, doing doing regular testing, maybe, and helping them with problem solving. How they can negotiate. If there will be roadblocks, definitely, but if we anticipate, we talk to them and we anticipate, yes, this is what roadblocks we expect, and help them with problem solving skills. I think this goes long way in helping them to continue to make sustainable changes.
Thank you so much, ma'am. I would like to go for the next question. That is for Dr. Bijli ma'am. Diet planning is a multifaceted topic and needs individualization. But in general, what are the primary food groups and food choices you believe must be considered in pre-diabetes care? Dr. Anjali ma'am, Dr. Bijli ma'am, over to you.
Yeah, thanks. So see, pre-diabetes has two major issues. One is that there is hyperglycemia, and the second is that there is this thing of insulin resistance. So both these things need to be addressed. Now, unfortunately, both hyperglycemia and insulin resistance contribute to each other. So it becomes a vicious circle. So the way to address that would be, of course, cut down on all simple sugars, simple carbohydrates, which would, immediately increase your blood sugar. So any food with a high glycemic index should be cut down, right? Because we're talking about pre-diabetes, not diabetes. So you're not stopping anything, but yes, you need to reduce. On the other hand, you need to limit fats, because what happens in pre-diabetes leading to the insulin resistance, that basically stems from a high blood sugar, which leads to hyperinsulinemia. Then that leads to accumulation of fat in the cells, which basically is leading to insulin resistance. So you don't want any fat and you don't want any simple sugars, right? So this is something that you don't want. But then what does somebody with pre-diabetes eat then? So it's not that you don't have carbohydrates. You do have carbohydrates, but you have whole grains. Actually, Dr. Varsha has already made my life simpler, because she mentioned a lot about what one must eat and the kind of foodstuffs we should eat. She also discussed the healthy plate. So in general, low fat, low simple sugars or simple carbohydrates. You must have a decent proportion of whole grains, because that contributes to a good fiber source. So your diet should be high in fiber. Now, fiber has a dual action. One, it reduces the absorption of sugars, reduce the rate at which the sugar is absorbed, hence reducing your, shoot up of blood sugar levels, especially the postprandial blood sugar. Also, over time, a high fiber diet can modulate the gut microbiota, counteracting any dysbiosis that exists. And all of us already know that dysbiosis contributes to the chronic inflammatory state, which is, which is there in pre-diabetes. So high fiber diet will counteract dysbiosis and bring it towards eubiosis. So that will also help in controlling the blood sugar levels. Now, another thing one should keep in mind is the plate method, right? Actually, in practice, like Dr. Varsha was saying, mostly people will say they're eating rice or roti. This is what they come up with. That they start with that and they also sort of end with it. Sometimes they say kabhi kabhi sabzi khate hain. So a good way to what I've seen in my practice is, when I start to tell them to change their diet, I just simply tell them, I just show them that healthy plate and I tell them, abhi, just half up vegetables and fruits. Say you fill it up with vegetables and fruits rather than filling it up with rice and roti. Just make that one simple change to start with. So of course, one other thing one must keep in mind when telling patients what to have is also that in pre-diabetes, mostly there is going to be an issue of weight. So one must also look at reducing the calories so that there is a weight reduction of at least 5 to 7% over time. So the calories would be, it's a low calorie diet, low on fat, low on simple sugars. Protein, of course, you need to decide whether it's going to be normal protein intake or high protein or low protein. As long as it's plant protein, actually low protein is not really necessary to be recommended even in renal diseases. So one can safely have the normal recommended protein even in renal patients if it's plant protein, right? So here we are talking about whole food plant-based diet. We're not going into any animal protein, so we should be safe. So yeah, besides that, fruits maybe a little less than vegetables. So when you say vegetables and fruits, fill up half the plate, more vegetables and less fruits for these patients. Over to you, Vindhya.
Thank you so much, ma'am. I would like to ask Miss Ila Pathak, ma'am, if you want to contribute anything to this question. If you want, I'll just repeat the question for you, ma'am. Diet planning is a multifaceted topic and needs individualization. But in general, what are the primary food groups and food choices you believe must be considered in pre-diabetes care? Ila Pathak, ma'am.
Good evening, everyone. Yeah, being a nutritionist, what we do in our clinic is one, apart from getting to know where the macros and micros are coming from, the one intervention which we definitely do is change the way the food is eaten. And the same amount of food, same amount and quantity of food, if eaten in a certain way, has a great impact on the body. So by changing the way the food we eat the food, almost 75% of the sugar spiking can be controlled. So we tell our clients to eat the vegetables first, second, the proteins and the fats come, and last is the sugar and the starches. So when we eat the veggies first, the fiber in the veggies actually forms, when it gets to the intestine, it forms a kind of gooey mesh on the intestine, on the walls of the intestine, and it reduces the intake of too much of glucose quickly from the food that follows. And that mesh stays there for some time, and hence probably it happens that we are done or we are full by the time we reach the sugars and starches portion of the food. So this is how we can actually control. When we are on a whole food plant-based diet, we feel satiated on foods that are low in calories.
Thank you so much, ma'am. Coming to the last question of today's discussion forum, that is again to you, ma'am. Prediabetes and metabolic syndrome. How do these two conditions differ from each other? And do we have to take different approaches while managing these two conditions with lifestyle interventions? How genetics affect these conditions, and with evidence-based nutrition interventions, how can we surpass genetics' role in the causation of diabetes mellitus? Over to you, ma'am.
So, metabolic syndrome, I would say, is an umbrella term which includes a cluster of elevated risk factors which lead to diabetes, cardiovascular issues, stroke, or all three of them. And diabetes, the diabetes and diabetes is a part of this umbrella, I would say. So when it comes to genes and addressing these two, I think we need not take different approaches to both these, because the pre-diabetes and the metabolic syndrome, they go hand in hand. Some clients come with only pre-diabetic conditions. Some show the show all three, which encompass the metabolic syndrome. When it comes to genetics, genes behave in a certain way. Like the genes for the color of our hair or for the color of our eyes are called dictator genes, and they can't take no for an answer. So if they want us to have a particular kind of hair color or eye color, so be it. But the genes for diabetes, diseases like diabetes, Alzheimer's, they are like committees. They just suggest. And research says that diet and lifestyle intervention can actually suppress these genes from expressing themselves. So they'll remain like seeds on a desert floor, and if you don't water them, they won't sprout. Usually we say that the diabetes runs in the family. To some extent, it is because of the genes, but the genes express themselves because a kind of diet and lifestyle pattern follows in the family for generations. So when it comes to intervention, I would say managing the fat. And when you are on a whole food plant-based diet, the managing the fat becomes easier, because saturated fat is something which actually is responsible for insulin resistance, leading to diabetes. Second is when you are on a whole food plant-based diet, you need not worry about calorie counting or portion sizes or cutting down meals, which actually becomes easier for the clients to follow, because when we prescribe diets, they should not feel that they are restricting themselves. We don't want to restrict the patients, they should feel that they are able to enjoy everything, everything that comes in a diet. They should not feel that they are on a diet, basically. And of course, lifestyle interventions, like we assess the patient for how much, what is the kind of his diet, what kind of lifestyle in the sense of his exercise regime, sleep, stress, as mentioned beautifully by Dr. Basha. So these are the things we address, and then it helps us address both the issues, pre-diabetes as well as if someone has come with a metabolic syndrome.
Thank you so much, ma'am, for the information. I would also like Dr. Anjali, ma'am, if she has any inputs on the same question, pre-metabolic syndrome, whether genetics have any effect on it, and whether evidence-based nutrition intervention can surpass genetics. Dr. Anjali, ma'am.
Yeah, so in diabetes, when we the dominant or the gen there are very few types of diabetes which have a very strong genetic component. Most of them are, there are SNPs. While there are many SNPs, single nucleotide polymorphisms which are associated with diabetes, but it is not as if that if you have a SNP, you are destined to have diabetes, as has been very clear, very nicely explained, that we need to be working with our diet and with especially with the diet, in fact, on how our genes are expressing themselves, and that is how we would in fact, not just with the diet, but yeah, majorly with the diet, but even the other parameters are very important in gene expression. And even disturbed sleep has over a few days has been shown to with the gene expression of many of these SNPs which are associated with diabetes, it is changed. So I think just to say that yes, there is a genetic predisposition is not enough. It is more important to see what we can do to modulate that, and to try to overcome those genetic predispositions. And quite often we can do that.
Thank you so much, ma'am. I think with this, we have come to the end of the discussion forum of this month. I would like Adishna ma'am to carry forward with the summary and vote of thanks. Over to you.
Thank you so much, ma'am. Thank you, everyone. So just to summarize what we learned today, we learned a lot of things today. So starting with Dr. Varsha ma'am's question, and then she answered very well about how to screen and what are the causes of prediabetes, HbA1c being one of the screening tool. Other than that, she talked about fasting insulin, HOMA air, and also to differentiate between type 1 and type 2 diabetes, that is 1.5 diabetes. She also talked about the importance of visceral fat, along with obesity being one of the cause, but mainly the visceral fat, and physical activity, wrong or improper dietary habits being one of the cause of pre-diabetes. And when she talked about counseling as one of the important tool to talk to the patient when he or she comes to you about the pre-diabetes, and then we have to talk about how changing the lifestyle can prevent the progression of pre-diabetes to diabetes. And so there were a few points which she pointed out, like changing the diet to whole food plant-based diet, physical activity being one of the important cornerstone of it, intermittent fasting, sleep, and stress reduction, good interpersonal relationship, one of the points she talked about. And then Bijli ma'am talked about the pharmacological care. So the earlier, and she talked about the importance of lifestyle modification as one of the frontline treatment for pre-diabetes. And the earlier you start the intervention, the better the results. she talked about the in particular when it comes to cardio-renal issues, we'll have to individualize the treatment. So it depends on the individual what has to be done. And so she talked about starting with a lifestyle modification, and then if we don't see any changes for 6 months, then we can go to the pharmacological care. Next, Anjali ma'am talked about how can we make our patient to follow lifestyle modification. She told about that behavior change is a process. It is a slow process, but you eventually lead towards the goal. So starting with target, keeping a target, setting a goal, then being behind, tracking the result, tracking the changes which the patient is going through. You have to be practical when you are giving the guidelines. You can use digital tools, online groups which can support uh, uh, the 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 patient or the person with prediabetes. Family support is one of the cornerstone, and as is an important uh, uh, part of the process of treatment. And uh, and the family has to be in the picture when you when you give the treatment, when you plan the diet or the lifestyle modification for a patient. Then Bijli ma'am talked about pre-diabetes, the two important things, the hyperglycemia and insulin sensitivity. These two issues are to be addressed, and it is a vicious cycle which has to be looked into. The don't wants, like you have to cut down on simple carbohydrates, limit fats, add in more of whole foods, which add in fibers, which help to reduce the rate at which sugar is absorbed, and also it modulates the gut microbiota, which is important in maintaining the sugar response in our body. Reducing the cause, reducing the calories, or maybe reducing the weight, which is common, which is one of the reason for pre-diabetes. Protein can be in particular to plant-based diet. It can be taken according to the normal, what is recommended normally. And fruits can be a little less, and vegetables could be increased. Ila Pathak ma'am added to it, and you have to change the way the food is it, and maybe starting with the vegetables, more of fiber initially, and then and gradually you come to sugar, so that you are already satiated as you reach towards the sugar and fat or starch. Then lastly, Ila Pathak ma'am also added on metabolic syndrome and the part of genetics. And she said that pre-diabetes is a part of metabolic syndrome, but metabolic syndrome is an umbrella term, and diet and lifestyle intervention can actually suppress the expression of gene. So when you are saying that you are genetically predisposed to pre-diabetes or diabetes, but if you have taken care of the lifestyle modification, so probably you can delay or maybe prevent the pre-diabetes or diabetes. With this, I would say I would
Deshna ma'am, sorry for interrupting you. Before concluding, I think we should take questions from audience.
with the vote of thanks. I would like to giving their point of view for this. But yes, sir. Yeah, I just forgot. Maybe is there anyone has any questions regarding this pre-diabetes? That would be really nice. Participants, if you have any questions, we are open to questions now.
One of the most commonly asked questions that I get is, if can physical activity compensate for a bad diet? Bad diet is not changing your diet. So I always say you cannot outrun a bad diet. Whatever amount of physical activity you do, if you do not change your diet, because I've seen marathoners having diabetes and people who do physical activity also having chronic conditions. So especially youngsters ask this question a lot, that if without changing, if I continue to have my animal products, I continue to have my dairy, I continue to have junk food, and I exercise, like instead of 1 hour, I exercise for 2 hours, will it not, will I get better? So I just wanted to know what other panelists would like I always strongly believe, and they do see it when they do it, but convincing that particular youngster or a young adult is a challenge at times.
I agree, Dr. Varsha. It's not necessarily a question from them all the time. Sometimes there is a very strong belief also that, if they continue to, if they increase exercise, then whatever they're eating, it's not going to have any bad effects. That is also then, especially in the youngsters who are educated, because they read a lot on the internet and they get this information. They come up saying, I'll have apple cider vinegar in the morning, I'll have 2 hours of exercise, and I'll lose weight. The rest of the day I can eat whatever I want. So, and especially in those who are not really gaining weight, they don't foresee the future being any different. They feel they will go on like that forever and ever. So it is an issue. More education needs to be done, I guess.
Yeah, here I would like to add, by a bad diet, I would say a high fat diet, low in good carbs, and even in healthy individuals, a high fat diet actually impairs the body's ability to handle sugar. So a high fat diet, and within 160 minutes, you see the insulin uptake getting affected. So exercise definitely won't actually compensate for this kind of, I would say, the damage which is being done to the body handling the sugar. So diet definitely plays a major role.
Yeah, so what I usually tell them, see, even if you are doing severe intensity or moderate intensity exercise also to a certain extent produces some inflammation in the body, and you need anti-inflammatory foods. The obsession is with chicken and paneer and dairy products. Is that what I commonly come across? So there is a lot of neglect for fruits and raw salads in this group of patients. So I always tell them that whatever inflammation that exercise also causes needs anti-inflammatory foods. But somehow I cannot get through them, means that to get my message across, whether it's scientifically or otherwise also, many a times I'm at a loss at this. So I was like, what do you all do? How do you convince such patients?
So people who are into high intensity training, they usually look down upon carbs. But actually, when you don't have sufficient carbs, there's something called a protein sparing action. When the carb intake is not enough, the body actually cannot spare the protein for what it is meant to do, like repair work. And I have seen people who are into intense exercise, they actually don't want to load themselves with carbs, only uh, on the in when they are running a marathon, they do the carb loading. Otherwise, they just don't take enough carbs, which is wrong.
Yeah, because
So
then
we
you
have to actually educate them.
Yeah. So in the initial modes of running, whether it's a marathon or even a moderate or high intensity workout, initial energy you get is from burning that stored glycogen, right? So if you're not going to take carbs, from where are you going to get the glycogen stores? So see, I understand all of this science, but to get it across is a challenge for me at times.
Here, I think this is what the COM model that I mentioned, where we need to look at what exactly they are the patient's perception, and then address them one by one, or then address them actually. However, it is not so easy to, because normally we just say, they just listen and they go out, and maybe their gym trainer will say something and that's fine. That's the final word. And so I think one, to explain to them, but to
Ma'am, your voice is cracking.
and hello.
It's
You
okay
need
now,
to
ma'am.
change
Yeah,
the
now it's okay.
network.
It's
okay?
now, ma'am.
Yeah.
It's okay. Yeah. So, okay. So, basically, just to get them to understand and to have these positive reinforcement during the program. So that is the reason why a single consultation will not have as much impact. Actually doing a program, calling them every week, and that's what the deep diabetes prevention program has been designed as. So the first 16 weeks of intensive weekly sessions, and then of course you can make them less frequent, but reinforcing them, making them, okay, you just see just decrease the protein, or to show them that yes, you are taking enough proteins from the plant sources, and those decreasing the fat amount, the amount of fat, all these things, but once they start doing one by one, and they start seeing the numbers go down, or they start feeling better. I think that's where they get more motivated to make the change, and they understand these having said that, there will be a subset of patients who will not understand, or who are not willing, and where the social pressures, the peer pressures are very strong, and they're happy to go on medications.
Yes,
Thank
ma'am.
you.
For the counseling for this kind of call behavior, as you earlier, and it is not a
Sorry, your voice is
take
breaking.
for process. It is a continuous. Am I audible now? Hello?
Still, it's breaking.
Am I audible?
So are there any other questions? We'll take one more question, and then we can go with a vote of thanks. Okay. Yeah, one of the participant had this question, like most of the doctors suggest skim milk powder as for diabetes, mostly for as a protein source. And also they suggest not to go for fruits. So what is your take for this? Most of the doctors do that.
So skimmed milk powder.
Yes, ma'am.
I'm not aware of doctors really prescribing. I mean, so what is the purpose?
So for protein source, they suggest going for skim milk powder, and usually they would suggest that, because this was last time one of the participant had this question. She said that in Bangalore, usually where she works, the doctor suggests go for SNP, like skim milk powder, as a protein source. So what is your take for that?
No. Here we are advocating for a whole food plant-based diet, cutting down on dairy. So skim milk powder would be a no-no. There's no need for that. There's so many better plant sources. Why would you go for skim milk powder? No, that would be
Yes,
no.
so even the nutritionist, like she suggests, but when the doctor says no, you go with SMP, so patients usually go and listen to the doctor over the what the research says or what the evidence says. So this is most commonly seen. Okay, yeah.
I don't know, maybe others can, others are aware of who's prescribing skim milk powder.
No, a lot of doctors, especially general practitioners, what they say, instead of whole fat milk, go in for
Skim milk.
skimmed milk. Yeah. So that is what I have heard patients come with, but not about the powder. They replace
Right.
that whole fat milk with skimmed milk or that low fat milk. You know that here you get the Amul low
Toned
fat
milk.
toned milk or that.
That's
But
a step in
powder,
the right direction.
yeah, powder I have not heard about. Powder is highly processed
Highly processed, highly condensed.
and contaminated also at times with metals. You know.
Sure, and thank you so much. I will continue with the vote of thanks. So it gives me immense pleasure to continue with the vote of thanks. Uh, uh, I would like to express our deepest gratitude to our distinguished speakers for sharing their insights and expertise. Your thought-provoking point of view have enlightened us on the crucial aspect of pre-diabetes, providing us with valuable knowledge and practical approaches to address this growing health concern. Next, I would like to thank my deepest appreciation to Pan India and our dedicated organizing team and volunteers, whose hard work and meticulous planning have made this event seamless and successful. Your efforts behind the scenes are the backbone of this forum, and we thank you for your unwavering dedication. Lastly, to all the participants, thank you for your active involvement, thoughtful questions, and for taking time to be a part of this important discussion. Your enthusiasm and engagement are what drive the success of such forums, and we are grateful for your participation. As we conclude today's forum, let us carry forward the insights and knowledge gained and continue to work towards preventing and managing prediabetes in our communities. Together, we can make a significant impact. Thank you once again, and we look forward to your continued support and participation in our future endeavors. Thank you so much.
Thank you.
Thank you.